Are women going to die if they can't access an abortion? What do we do in the cases of miscarriage and ectopic pregnancy? Every question you have wanted to know the answer to on abortion will be answered today by Dr Donna Harrison. And that's today on a very special episode of the Dr Jo Show. Today on the show, I'm really pleased that you'll be able to meet Dr Donna Harrison. I met her last year when she flew in from America for the National Life Summit, which was a sold-out event we held at the Fullerton Hotel. We have another summit this year in Brisbane on November 30, so make sure you're following along on social so you don't miss out on tickets for that event. There's no doubt they'll sell fast. When I sat down with Dr Donna Harrison, I wanted to put to her all of the questions that you and I have on this issue. And I wanted to play devil's advocate because it's really difficult to separate fact from fiction in this debate on abortion. There's just so many media articles that pull in different directions. And I thought, to be able to speak with someone who's worked and lived in this field for over 30 years and is really up to date on the research was just a wonderful opportunity for us. So the night before the summit, I sat down with her and asked her all of these questions. You'll want to get out a notepad and a pen because her answers are rich with facts and data, and that'll help you in the conversations that you're having with people in your life about this issue. And so I also just want to take this opportunity to say thank you for following along on this podcast, for supporting the Dr Jo Show. If you haven't subscribed, hit that subscribe button, make sure you've rung that notification bell, and please do keep sharing these videos and writing comments because everything you do helps spread this further. So let's dive in with the first question. What about when abortion is needed to save the life of the mother?
There's a difference between separating the mom and the baby when the mom's life is in danger and intentionally killing the baby.
Yeah.
So when the mom's life is in danger, if the baby can survive outside the womb, we do a C-section or we do a vaginal delivery in a place where both of them can be taken care of, and we don't intentionally kill the baby. If the baby can't survive outside the womb, we will still separate to save the mom's life.
Yep.
But we won't intentionally kill the baby. We'll deliver that baby with as much dignity and respect as possible, in part because moms and whole families heal better when they have a baby that they can mourn instead of pieces of a baby that happen with a second trimester abortion.
But what about for an ectopic pregnancy? Yeah. Is the treatment for an ectopic pregnancy to kill the baby and therefore an abortion?
No, the purpose of the purpose of treating an ectopic pregnancy is to separate the mom from the growing placenta in her tube. If you don't separate the mom from the growing placenta in her tube, the tube will rupture and she will die. And so we know that we have to separate the mom from that placenta and the baby that's growing inside, but we don't go in specifically to kill the baby. Whether the baby's alive or dead at the time of the ectopic procedure, the point isn't to kill the baby. The mom isn't saved by the baby's death. The mom is saved by taking the growing placental tissue out of her tube.
But what about, I can never say her name, but the lady that passed, Savita
Halappanavar.
Yeah. And so what I understand of her case was that her baby hadn't died yet, but she was miscarrying and there was some delays in her treatment, and then she did pass from sepsis.
Yes,
is that right?
She did.
Could you... People have said, well, she's the emblematic example of why you need abortion to be legal so that women who are miscarrying can have access to it.
But her case had nothing to do with abortion legality. Ireland allowed for separating the mom and the baby if there's a threat to the mom's life.
Yeah.
So the Irish law was already able, she was already able to be treated. You can't blame malpractice on a law that would allow for treatment.
Yeah.
And the problem was that she was getting sick and nobody was watching her. And that's the problem. So when you have someone who has ruptured membranes, you have to monitor them. You have to watch their temperature, you have to watch their white blood count, you have to watch for signs of infection. And at the moment they show signs of infection, you separate.
Yeah.
Regardless of whether the baby is alive or dead at that point, you separate because that's a life-threatening situation for the mom.
And I read the reviews of her case and it was very different to what the media, the Guardian in particular, was reporting. They were saying this was a woman dying because she couldn't get an abortion.
That's not
and
true.
The actual hospital board report indicated what you said, malpractice.
Yes.
That the doctors were not vigilant enough at the time and didn't give her care. So what I'm hearing from you is that after viability, which is generally understood, if I'm correct, at 22, 23 weeks?
Yes.
Okay. So after viability, there's actually never a medical reason ever to save the mother's life to kill the baby. Like, you just don't need to do it.
That's correct.
Yeah.
Because you separate them in a situation with a neonatologist present in a NICU, and a situation where both of them can get excellent care. You recognize the humanity of both your patients, and you care for both of them.
But just to play devil's advocate, aren't you consigning then a baby who's 23 weeks to months in the NICU and potentially lifelong conditions that are going to threaten that child's quality of life?
Well, I don't think that just because somebody has a life-limiting condition that we kill them. We just don't go out and shoot people with Down syndrome. We don't go out and shoot people that are handicapped from an auto accident. Civilized human beings don't do that.
Yeah. But have you ever been presented with a situation after 23 weeks where a mother has presented to you and said, I cannot do this, I am going to kill myself, I have no support, no money, I need you, I need this abortion to save my life? And it's a mental health situation, but it's a really severe one. What do you do in that scenario?
She's treated for depression. She's supported. Abortion is not a mental health treatment. We don't go in and automatically abort women that have depression or suicidal ideation. We treat them for suicidal ideation. We treat them for depression. We give them the support that they need. We don't just assume that killing their baby is going to be the answer for what is really situational. You go in and affect the situation. That's why pregnancy care centers are so brilliant.
So we had a situation in South Australia recently where I was part of a team that drafted a bill. I'm not sure if you were aware of it, but it said that after 28 weeks, for health reasons, a mother could elect to deliver that child alive through an early delivery, but that abortion, killing the child, was not acceptable, was not available. And so the pregnancy could be terminated up until birth, but intentionally killing the baby from 28 weeks up until birth was not possible. And there was a...
That's brilliant.
Well, you would have thought it was we thought it was non-controversial when we drafted it, but the abortion expert said that women will die, it will compromise women's health, that it will be forcing them to deliver really sick babies who are not going to survive, and that will traumatize the mother. So it's not compassionate to the child. That killing them in utero is much more compassionate than delivering them. The media and these abortion experts were calling it a forced birth bill. So I was just wondering if you could speak to that.
It's absolutely crazy. Show me the evidence that taking the baby out in pieces actually improves the mom's mental health versus delivering a live baby. They can't show you that.
Yeah.
So this is all theoretical, and it's all from an assumption that they want this baby dead.
Yeah.
Okay, if the true point was ending the pregnancy, like you said, the termination of pregnancy, this terminates the pregnancy. This ends the pregnancy with a living baby. So what they're saying is, we want that baby dead at all costs.
Yeah.
It doesn't matter. We do not want a living baby as a result of this. And I think that position underlines the pro-abortion position. It has nothing really to do with what's better for the woman, because women especially women who have late abortions, go through much, much more psychological trauma than women who deliver even unwanted, unplanned pregnancies. There was a great study out of New Zealand, actually, years ago, looking at women who carried unwanted, unplanned pregnancies versus women who aborted unwanted, unplanned pregnancies. And the women who aborted had an increased risk of drug abuse. They had an increased risk of major depression. So there was no mental health benefit from delivering. And I think that's something that people need to know. There's no mental health benefit from aborting a baby, from deliberately killing that baby.
And what does this do to doctors and nurses and OBGYNs and midwives who are being forced into this as a line of work? I mean, a lot of people, when I talk about this stuff on socials, they'll mention the Hippocratic Oath, but doctors don't necessarily have to say that anymore, do they?
Well, they haven't. In the United States, they haven't taken the oath as the real Hippocratic Oath for about 35 years. And I think that is really scary. If I were a patient, I'd be quite worried that my doctor never took an oath not to harm me. And I think when you walk into one room and say, Mrs. Smith, we're really happy, here you are, here's your ultrasound, you're 12 weeks pregnant, baby's performing well. and walk into the next room, Mrs. Jones, you want to get rid of the blob of tissue? We'll just pull that blob of tissue out. 12 weeks. You know, same gestational age. You can't, as a physician, comprehend both things.
And do you find in the US a lot of doctors and nurses and midwives don't want to do this?
There have been 3 national surveys that show that between 75 and 95% of OB-GYNs do not do abortions in their practice. And it's not because we don't know how. We can empty a uterus at any gestational age. It's because we know that there is another patient to whom we are responsible, and that's the patient, a human being inside that mom's womb.
What about severe preeclampsia?
Well, again, if her life is threatened, and she has preeclampsia prior to 22 weeks, you have to separate. That placenta is a problem, and she has to be separated from the placenta because she can seize and die. I think the mortality from seizing is around 50%.
And so you deliver the baby early?
Well, if it's below 22 weeks, you have to deliver the baby early.
Yeah.
And that baby won't survive.
And that's what you would do. You wouldn't do like a D&E and bring the baby out in pieces. You would deliver the baby.
You would deliver the baby for the mom's sake.
Yeah.
You know, you can use misoprostol, and women respond very well to misoprostol, and you can deliver the baby, and then the mom who has this wanted baby, and the family can acknowledge this is our son or daughter or grandson or brother or sister. Hold the baby and grieve. It's really important.
Yeah.
I mean, I've had a child who died myself, and the grieving process, it's critically important that you be able to hold your baby and acknowledge this person was part of our family.
Yeah.
And what do you have when you take the baby out in pieces?
Yeah.
You have nothing. It's horrible.
And then after 23 weeks, you can separate the mother and baby and the baby can go to NICU and then potentially
live.
Yeah. What are the chances?
Well, it depends on the situation under which they're delivered, but they've got a great chance of surviving.
What about a baby that's severely sick or got a condition that's incompatible with life and you've received that diagnosis? Don't you think the more compassionate thing to do, or that's what the pro-choice argument is that you do the abortion? You're saving that child from the pain and that family from the pain.
Well, you're not going to save any family from the pain of saying goodbye to their child. And I'll, like I said, I'll tell you that from personal experience. It's very, very painful to say goodbye. And it's less painful to say goodbye to a baby that you can hold and recognize than it is to say goodbye in pieces. Yeah. And the second thing is that there's a assumption that a baby who has a life-limiting diagnosis is suffering. They're not suffering. Their condition is not incompatible with life because they're alive. Yeah. You know, so if you're alive, it's not incompatible
so you don't
with
like
life.
That phrase? You don't think that phrase is accurate?
I think life-limiting condition is better. And ultimately, if you look philosophically, we all have life-limiting conditions because we're all going to die. But we don't hasten people's death simply because we're going to die. So in those circumstances, you know, you need to allow parents to be parents, and you need to allow this child the chance to live for as long as his or her life extends. And I'll tell you something else from personal experience. I had, with my 4th child, a diagnosis of a lethal congenital heart defect. I had already lost one son from a lethal congenital heart defect, and this son in utero was diagnosed with the same thing. 3 ultrasounds, baby's going to die. Again, I was going to lose another son. And he was born, and he didn't have it. So prenatal testing is not 100% accurate. Yeah. It is accurate within the limits of the test. And people look at sensitivity and specificity. The thing you have to look at is positive predictive value. So if you say, well, this test is 99% sensitive for picking up trisomy 13, but if you look at the positive predictive value, only maybe 1 out of 4 times, 1 out of 5 times is the test actually correct. So people are making decisions based on prenatal genetic testing that may not be accurate, and they're not being told, they're not being given informed consent.
Let's talk late term, after 23 weeks. If you go in for an abortion, what's the method that occurs?
Well, 24, 25 weeks, it's usually induction. Yeah. Okay, so some abortionists will cut the cord so that the baby bleeds to death inside, and then pull the baby out in pieces. Some abortionists will induce, but if you induce and you haven't killed the baby already, there's a chance that the baby is going to be born alive.
There is, yeah.
In which case, if you think about it, this is such an illustration of the purpose of an abortion. Because what do you call it when the baby's born alive? It's a failed abortion. The pregnancy didn't fail to end. The pregnancy ended. What failed to happen is the baby failed to die. So it's such an illustration that that is the purpose of abortion.
So with induction then, if it's after 24 weeks and it's an induction, the way they make sure they don't get a live birth is they kill the baby first. Can you explain that process?
Sure. It's done. It can be done in a number of different ways.
Yeah.
But sometimes by injecting a drug into the baby's heart or into the brain so that the circulation will allow for the baby to die.
Yeah.
It could be digoxin, it could be calcium chloride. And sometimes instead they go in and they'll cut the baby's umbilical cord so that the baby bleeds to death before the baby dies.
With the injection of potassium chloride or digoxin, what is the experience of the baby in that injection? Do we know?
Well, I don't think anyone who cares has actually looked at the study. I mean, these babies die in the same way that any other person would die if you injected their heart with calcium chloride or potassium chloride or digoxin. They have a heart attack.
Yeah.
So does that baby suffer? No one's looked. But we can say clearly that for fetal surgery, when a baby is undergoing a repair in utero, that they give those babies anesthesia because they know that the outcome is better. There are less stress hormones. So a baby is going to experience the same thing in utero that they would experience ex utero.
So there's such a disjuncture there between the anesthesia, the pain relief that's given to a baby in fetal surgery, and yet if you want to kill the baby, you just go straight in and inject.
Yeah, it's a complete denial of reality. And the reality is these babies feel pain, and the reality is their neural networks to perceive pain are present from 12 weeks on. So you have babies that are being torn apart piece by piece with no anesthesia.
So let's talk about that method. That's between 12 and 24 weeks.
Yeah,
it's called
22-ish.
Okay, so dilation and evacuation, is
That's
that what
correct.
And can you explain, you've said pieces, but what do you mean?
Okay, so the dilation part is the neck of the womb, the cervix, is opened, and that's the dilation part. And then the extraction part is the baby there's a grasper, there's an instrument that grasps the baby, that the baby that instrument doesn't let go. And so the abortionist pulls out whatever is grasped, and that's the first piece, and then passes in again, grasps whatever they can grasp, and that's the second piece. And then finally, what's left is the head, and the head is crushed with that instrument and
But how can anyone do that? Like, how can anyone do that? Rip apart the arms and legs and skull? Like, I just don't even understand how that can be called healthcare.
It's not healthcare.
Yeah.
It's not. It's population control, but it's not healthcare.
And it's at a point that the baby can feel pain.
Absolutely.
After 12 weeks and up until 22.
That's correct.
And so you're pulling out actual limbs.
That's correct.
Yeah.
And you have to reassemble the limbs. I mean,
What do you mean by that?
Well, you have to make sure all the pieces come out. So you have to put together and find 2 legs and 2 arms and the hands and the head. And you have to find all those pieces to say, yes, this is a complete abortion. First trimester abortion is done kind of in a similar way, but the baby's bones are soft. So that the way it's done is you put in a very powerful suction cannula. You put in a very powerful vacuum cleaner, and the baby is pulled apart in pieces through the tubing, through the suction tubing.
Yeah.
And then the placenta is removed by suction as well.
Yeah. So the other method that is used in Australia is MS2 step. It's the misoprostol
And mifepristone.
regime. Could you explain that one? Because that's actually probably the most common method in Australia.
So mifepristone is a hormone, an anti-hormone actually. It blocks the action of the pregnancy hormone progesterone. So when you give mifepristone, the first drug, then the mom's placenta can no longer feed the baby. So the baby starves, but doesn't actually pass, only about maybe a quarter of the time, half the time, depending on the gestational age, do you actually have the mom complete the abortion with just the mifepristone. So the second drug is given to cause the uterus to contract, and that's the cytotac or misoprostol. And then that's given, and how effective it is depends on how far along in the pregnancy the mom is. So if she's at just 2 weeks after she misses her period, then the combination will be effective maybe 95% of the time. But what does that mean? 5%, it's not effective. That means 5%, 1 out of 20 women will end up having to have a surgical completion. And sometimes that's with intense hemorrhage. Sometimes it's with other complications.
Yeah.
As you get out to about 12 weeks,
Yeah.
1 out of 3 have to have surgical completion. 1 out of 3. And a lot of times with massive hemorrhage.
And so these are those pills by post scheme, or in Australia, telehealth.
Right.
So meet a doctor over Zoom,
Right.
you get the pills in the mail, you take them at home. But you're saying 1 out of 3, if it was after 12 weeks,
right, would need surgical completion, and oftentimes for massive hemorrhage.
But isn't the World Health Organization saying it's safe for women to do that at the gestation?
Well, it's safe for the abortionist. It's safe for the person that's mailing it. It's not safe for the baby, and it's certainly not safe for the mom.
Yeah.
And what's really frustrating with that whole scheme is that the target is for women who have very little access to health care. So she's hemorrhaging at home. She can't get to a hospital, she dies. You know, you turn a complication that could be treated if she were in Sydney into a complication that's going to kill her.
Yeah.
And it's not just the immediate complications. If you look, these women are not actually getting informed consent because they don't know how far along they are.
Yeah.
So you would give the woman her risks based on how far she is. So you tell a woman at 6 weeks what her risks are, but at 12 weeks, her risk profile is very different. So she's not getting informed consent. She doesn't even know if she has a living baby if she's not had an ultrasound. She doesn't know where that baby's at. The baby could be in the tubes.
Yeah.
And if she takes the mifeprex and misoprostol, it will not take the baby out of the tube.
Yeah.
What it'll do is that baby will continue to grow, and the placenta will continue to grow, and she'll rupture. And what will she have? Pain and bleeding. Well, what's a mifeprex abortion look like? Pain and bleeding. And there's women in the United States who had massive pain and were bleeding, and they called the abortionist and they said, honey, that's just the product of an abortion, you know, just take a Tylenol and go to bed. And they died.
Yeah.
They died because they hemorrhaged internally because they had an ectopic pregnancy that nobody diagnosed.
Yeah.
And that's an absolute contraindication to mifeprex.
Yeah. So one of the things that I discovered last year, there was a Senate inquiry in Queensland. Sorry, not Senate, parliamentary inquiry in Queensland, because they only have one house.
Okay.
And it was into the issue of babies who survive their abortion.
Yeah.
Yeah. And an abortionist, Dr Alicia Broome, gave testimony on behalf of RANZCOG, which is our Royal College of Obstetricians and Gynecologists. And she said, when these babies are born alive, it's incorrect to think about them as failed abortions, because prior to 22 weeks, they're not going to survive. And this is our method of abortion. We give the woman the abortion pills. She delivers a live baby, but that is not an unintended consequence. But we just know that baby's not going to survive. What do you think about that method of healthcare? Or that method of abortion.
Right.
Yeah. And I should say healthcare with inverted commas.
Right. So you deliver a baby, a human being, intentionally for the purpose of killing that human being. There's something very sick about that. That's not healthcare.
And so you deliver this baby whole,
Right.
And then they place the baby in a separate room so that the mother doesn't see the baby, that the baby's whisked away. But with those babies, do they need if you don't provide resuscitation, are they just limp, or could they be crying or moving?
They can be crying, they could be moving, they can be gasping for air. They're human beings. And so
even pre-22 weeks, they can experience pain, and they may be whimpering.
They may be whimpering, but they may also be you know, retracting and trying to survive.
Yeah.
And they don't come out limp, they come out alive because they are alive.
Yeah.
And then they die in a very painful and lonely way. And this whole idea of, well, we're going to whisk the baby off so the mom doesn't see the baby. Let's think about that for a minute. Do you think she really doesn't know she was pregnant? Do you think she really doesn't know that there was a baby there? She will carry that with her the rest of her life.
Yeah.
The rest of her life. And this is, again, in situations where there is no choice, the mom is so sick that she has to be separated. In those circumstances, yes, the baby is not going to survive, but we put that baby on the mom's chest. We allow her to be a parent. We allow the husband to be a parent. It's an issue of recognizing the humanity of that baby and that baby's relationship to everybody else in the room.
In a recent Canadian study of over 13,000 abortions, and it looked at the incidence of live birth, one baby in that study did live for 24 hours. So these babies can live
absolutely
for quite some time.
Depending on the gestational age at which they're delivered.
And in your mind, abortion is killing a baby?
That's the reality.
Yeah,
I mean, you have a human being.
Yeah.
Human being from the time of sperm-egg membrane fusion. There's a complete separate organism with separate DNA, male or female, and that human being is going to grow continuously until that human being dies. So clearly there's a separate human being. There's separate circulatory system, separate DNA. You know, it's clear.
Yeah.